All right, we'll start by introducing things. Hi, everyone. Thank you for joining us today. My name is Salman Rafe. I'm the program manager at the Mickel Institute. I just want to give a very brief introduction before turning it over to our main speaker. But this is, kind of one of the highlights of the year every year. The fellowship program is one of the best parts about being here at the Mickel Institute, both for our fellows and for us. It allows us to bring a cohort of very diverse and high-achieving emergent scholars from the South Asia region here to Harvard. Which is not only a boon to their experience and research and academics, but also to all of us on campus to connect with, again, a diverse set of scholars and academics. So for those of you who are here today, obviously we're glad that you are here, but I also encourage you all to connect with these scholars outside of just these seminars for the remainder of their term, and of course, further on from here. The Bajaj Fellowship in particular is in fact our newest fellowship. We've only had two in the past year or so. So it's been a good two of two have been pretty great so far. I'd like to keep that up. But it's a program that allows us to bring a scholar from the region to Harvard for about a half a year. And that's thanks to generous support from Jamnalal Kaniram Bajaj. I'd also like to give appreciation for the support provided by Hitesh Hathi, our executive director, and our program and admin coordinator, Danielle, who manages our fellowship program. Both of them couldn't make it today, so instead, for better or worse, they've sent me in their stead. And I also just like to start by introducing the faculty mentor for our Bajaj Fellow. Our faculty mentors support our fellows the whole time that they're here at Harvard, and sometimes even in advance of their arrival, including serving as their seminar moderators. In this case, we have Dr. Winnie Yip from the T.H. Chan School of Public Health. Professor Yip serves as Professor of Practice of Global Health Policy and Economics in the Department of Global Health and Population there. She's also the faculty director of the School-Wide China Health Partnership, and also recently completed a stint as the acting director of the Fairbanks Center for Chinese Studies here at Harvard, just our downstairs neighbors. Among a variety of things, which I'll be very brief about, Professor Yip's research focuses on rigorous and policy-relevant health system evaluations and the design and testing of innovative health system interventions to improve equitable access to efficient and good quality healthcare. Dr. Yip, thanks so much for joining, and I'll turn things over to you.
Great, thank you very much for the giving me the opportunity to work with Kaya, and it has been a very educational experience for me because I've learned a lot from her. Kaya is, of course, she's the Bajaj Visiting Fellow here this year. She's also an associate professor in healthcare management at the Goa Institute of Management in India. Her area of research is in health system financing and public health. And her recent research focuses on policy implementation and evaluation of the very big public program, PMJAY, which she will talk to us about it in her talk. And before she became an academic, she actually worked at NITI Aayog, which of course all of you know is the policy think tank for the Indian government, and has really amassed lots of experience from that experience. At that time, she actually had contributed to the health chapter of the 3-year action agenda for Government of India, the NITI District Hospital Index for monitoring the performance of public hospitals, etc. I'll let you read her CV so that we can leave plenty of time to hear her very interesting talk today. I'll just preempt by saying that the sort of establishing government financed social health insurance program is a worldwide trend. A lot of studies have been trying to look at the impact of these programs, but very few actually look at how these programs are actually organized and also governed. And I think today her talk is filling an important gap. So over to you.
Thank you so much.
And I'm going to leave you to tell the audience whether you want them to interrupt you whenever they want to, or do you want them to hold the question until the end?
Okay, sure. Thank you so much, Professor Yip. And good evening, everyone. Thank you for being here. I'm really honored to have such experts in the room. So today, as Professor said, what I'm going to be presenting, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is extremely popular, and schemes like this are extremely popular. My project is really on a very specific aspect, which is the organization of purchasing, which isn't, if I'm being honest, as glamorous as some of the other work that's done around PMJ, but really a key part of whether things can work or not, because it's some of the nuts and bolts issues into how purchasing of care in this scheme is really carried out. And so before I go to that, and I'd like to set a little bit of the context. I know some of you are very familiar with the subject matter, but I'd like everyone to sort of be on the same page. So allow me a little time to sort of speak to the context a little bit. PMJ's place in India's overall UHC journey, the organizational structures for strategic purchasing, which is, government versus insurance companies, and then the motivation for this particular work. Coming then to the research questions, the methods, and the findings. And the findings will be first around the composition and governance of these purchasing agencies, and then looking at really the performance. And the performance, what we focus on is on access, on the management of claims, and the administrative costs to the government in employing these models. And then I'll end with the summary of our findings and what the implications for policy are based on that. All right, so as Professor Yip rightly said, several LMICs over the last 2 decades or so have really been adopting these publicly financed insurance schemes as one of their UHC strategies. And what most of these countries really share in common is the fact that most of them have publicly funded and delivered healthcare services, but due to resource constraints, they don't meet people's health needs. Although they're available free of cost at the point of care or at very low costs, they don't manage to fulfill population health needs. Subsequently, you have a large private sector that develops, but that requires the incurring of high out-of-pocket expenditure, leading to catastrophic health costs. And so these are the schemes that really come in to take care of that problem. Similarly, India launched the PMJ in 2018. And if you look at it, PMJ essentially is for hospitalization access. It covers secondary and tertiary care to the lowest socioeconomic strata. So this represents the bottom 40% based on socioeconomic indicators. Now, PMJ didn't come out of the blue, really. It was built on an existing program, which was the RSBY, the Rashtriya Swasthya Bima Yojana. And I'll come back a little bit to what the differences are and how it was built on that. In 2018, when it was announced, it was announced along with another component, which was for primary care, the health and wellness centers. And since then, this overall Ayushman Bharat, when you hear this word, it encompasses a number of schemes. So you have the health and wellness centers, PMJ, but now over the last couple of years, you also have the National Digital Health Mission and the Infrastructure Mission. And so this is really one of the central strategies, but amongst a plethora of interventions aimed at universal coverage. So like I said, PMJ doesn't stand alone. So a little bit of where it, it sits on this base of primary care. And so the primary care for all income groups, you have publicly funded delivered services for preventive care and primary care. And then you have PMJ, which fulfills the requirements of secondary and tertiary care. And along with PMJ, you also have state insurance schemes. Now, many states, even before and since, have started their own schemes, and these have integrated largely with PMJ, most of them. Now, what do these do? PMJ is set up for the bottom 40%, as I mentioned. Some states may choose to expand those benefits to people above that 40%, to more people in their particular state. Or they might also choose to expand access to higher levels of care. So, more expensive treatments included in the benefits package and that sort of thing. All right, so that is also part of the entire thing. And of course, then you have these other insurance schemes. I won't go into all of that, but you also have other schemes that are either social health insurance schemes, and then you have voluntary health insurance and that sort of thing. But when states expand, they do it at their own cost. What we're focusing on today is largely the PMJ program. So coming back to this, building on RSBY, which existed before that, As you can see, RSBY was really, it had a limited set of services. So if you look at it, the benefits package, about $366 or 30,000 Indian rupees, which is really a small amount for a family of 5. Okay, so even if the family was larger than 5, only 5 people could be covered really. And so because of the small benefits package, it was limited to secondary care. Now, PMJ expanded on that along all the dimensions of UHC. So in UHC, we usually talk about 3 dimensions. The first, service coverage. So it includes now secondary and tertiary care services. So it's not limited to only secondary. And it does that by also expanding the sum assured, okay, to about 5 lakh Indian rupees or $6,100, which is of course a manifold increase from the 30,000. So this allows it to offer tertiary care procedures as well. And of course, all of this is supposed to be free at the point of care, no user charges, all of that. In terms of the population coverage as well, there is some expansion in that, there are no limits on the family size, and the criteria used here is the socioeconomic and caste census. That's what SECC stands for, which identifies certain categories of the population that we call deprived categories that become beneficiaries of the scheme. All right, so in this way, it's expanded and built on RSBY. All right, sorry. Okay, the other thing of note here, this has remained the same, it's tax funded, center state shared, financing 60% from the center or 90% depending on the state. What's important to note is that, in RSBY, largely the schemes were implemented by, a government department within the ministry, and then a contracted insurance company managing most of the scheme. Whereas for PMJ, a new agency was set up, which is the National Health Authority. Now, the National Health Authority originally was meant to be an autonomous agency. It's not exactly autonomous, but at the same time, although a part of the Ministry of Health, it's headed by a very senior bureaucrat who usually reports directly to the minister. Doesn't necessarily have to go through the Secretary of Health and that sort of thing. So there is some level of independence of the NHA from the part of the ministry that really owns and delivers publicly funded care. So most states have adopted the scheme with the exception of Odisha, West Bengal, and Delhi. They have their own schemes. So what has really been the experience with all of this before, with PMJ before? Like Professor Yip also said earlier, the emphasis has been on impact. And in terms of impact, what have we seen? If you looked at the main outcomes, I'm not going into all of that, but access and financial protection. Any of these schemes, the main things you want to look at is, has it improved access to care? Has it improved financial protection against catastrophic health expenditure? If you look at these 2 indicators mainly, you see that evidence shows that access has improved usually. People now have access to hospital-based care. But in terms of catastrophic expenditure, you'll see that there has not been a significant impact as such. In some cases, out-of-pocket expenditure has even increased because of the limited benefits package or because of practices of private hospitals to balance bills, so on and so forth. But what was important to note is why was this happening? And a lot of studies identified that there were limitations in the design of purchasing arrangements, in the structures that were created for purchasing, and the oversight of all of this. So really the nuts and bolts of what organizations were set up, how they were functioning, and the governance of the scheme by government to do all of these functions. And I'll explain that a little more later. So what happens in PMJ? What's different? The purchaser in PMJ is usually the state governments, okay? And that's usually what we call the trust model. Every state has a state health agency, which is the counterpart of the National Health Agency. Now, this state health agency can purchase care directly from public and private providers on behalf of the beneficiaries. Alternatively, they can contract with an insurance company. So that's where the commercial insurers come in. So this trust can contract an insurance company to purchase services on behalf. And what we've seen is that about 6 states have adopted the insurance mode, and about 4 states have adopted a hybrid mode, which combines both, but largely based on what we've seen in states is even in the hybrid mode, the larger dependence is on the insurance company to do most of the claim processing. All right, so these options were given to states, and so you have these two modes, which is the trust and the insurance mode. And the reason why states are given these options is really to fulfill capacity constraints, because it's difficult to set up a full government body to handle such a large scheme. And so to give states the option to be able to outsource some of this work, you have insurance companies coming into the picture there. So what does the evidence say on trusts and insurance companies specifically? What has been the example, the evidence with RSBY and with other state schemes like Arogyasri and the other schemes that existed before with these two models? Now, mainly focusing on the insurance, we saw that, as you know, commercial insurers have incentives to really minimize their claim payouts. And they would do this by curbing access to care, by rejecting a large number of claims so that profits could be maximized. And this was quite clear in the insurance models earlier. On the other hand, trusts weren't perfect either. With trusts, there were lots of efficiency issues. It was difficult for trusts to really manage large schemes like this, absorb financial risk. Really, the expertise that was required to process and pay providers, process claims and pay providers. And what was seen is that the reasons for some of these failures was because the contractual arrangements did not allow for sufficient governance and oversight between the public payer and the purchasing agency. And so these contractual arrangements, if they were in place, they weren't sufficiently enforced, or they were not even designed in a way that really aligned the incentives of the public and private stakeholders in this purchasing structure. And so, you know, and maybe I won't go into this, but these sorts of arrangements are available in other countries as well. You know, Nigeria did this in their insurance scheme. In the US, Medicare also contracts insurance companies to process Part A, Part B plans. And here as well, you know, there are performance appraisals, there are mechanisms for review, but really enforcing them is what is, you know, is the crux of the matter. But you see here as well, incentives aren't always aligned and there can be issues. So, you know, why are we finally doing this? Clearly, there are some problems with both the models. PMJ allows both models. What motivated this particular study? So in 2018, when the scheme was launched, you know, because of all these bad experiences with insurance companies, there was kind of a push to states to adopt the trust mode. You know, there was a little bit of fear of the things that would have happened if insurance companies came into play. And so states were kind of encouraged to adopt a trust mode and to avoid insurance companies as far as possible. But then, of course, many states couldn't do this. They didn't have the capacity. They had to go ahead with the insurance model. And so central policymakers were very keen to understand what the experiences were in the states. You know, whether the models were working. Most importantly, were the earlier observations on the performance of trusts and insurance companies, were they holding true in the current structure? Are the governance arrangements that they had put into place, were those really working? And, you know, what was the effect of that? And so we did, you know, just to look at these questions, an early assessment. Just 6 months into the scheme, we looked at one trust state, UP, and one insurance state, Jharkhand. But this was very early into the scheme, the first piece of work that we did, but it allowed us to sort of understand really the details of how these models were set up in each of the states, and also to fine-tune our assessment that we then brought into this larger study that I'm presenting this evening. So the larger study basically was informed by the first study, which was an initial insight. Those insights were interesting, but they needed to be corroborated through a larger study. And that's what we did. So like I said, you know, it helped us really hone in on the framework. The framework we use for this is that of strategic purchasing. You know, many of you know what this is, and really in purchasing healthcare, you know, the 3 key decisions that need to be made: what health services to purchase. Okay, and this is basically your benefits package. What should be included in a benefits package? What kinds of treatments? From whom to purchase? Which provider should be providing care? So who are we paying and, you know, to provide care for the beneficiaries? And how to purchase. And this is basically your payment mechanism, both the way in which payments, you know, the kinds of payments, in this case, which is case-based payments, and also the prices. And then, of course, you have the process of managing claims and managing financial risk, prevention of fraud, and all of that. Now, if you look at it in PMJ, in the current arrangement, all of these functions have been retained with your trust, with your state health agency, which exists in all the states. And the only functions that have really been, outsourced to the insurance company are those of managing claims and financial risk. And so that sets some kind of limit on what decisions can be made and by whom. And so you see that, if you want to compare performance, you compare performance, therefore, on these aspects, all right? And then, of course, the most important thing in strategic purchasing is what is the contractual arrangement that brings all of this together. Okay, so whether it's a trust or whether it's insurance company working with the trust, what are the contractual arrangements in place? And so based on this, our research questions were the organization of purchasing across the states in the current study. Was it the same? Were there some variations? And then the comparative performance. And if you look at it, therefore, the comparative performance is based on the hypothesis. Like I said, insurance companies usually have the incentive to not pay out claims, which means that they're placing limits on access. So are we seeing that trust states have better access to care? Is there higher utilization in trust states? Do the insurance states report higher claim rejections? Because that's also something that was very clear in the earlier experiences. And how does the claim management efficiency compare between the two models? And then to look at what the governance and contractual arrangements were and how those could be used to explain our findings on performance. All right, so we looked at indicators of performance, which is usually quantitative, and then the qualitative part is really trying to link the governance and contractual arrangements with those findings to figure out why this is happening. And then, of course, an important part of the story, which usually matters a lot to government, is what are the cost implications to the government for, with either of these models, because sometimes the decision can just come down to that. All right, I'll just go quickly through this. These are comparative case studies of 6 states, 3 trusts, 3 insurance. And then we have a mix of data sources. So we have claims data, administrative claims data. We did 3 years of data from the start of the scheme till March 21. Individual claims data for detailed analysis was 3 months of data, and that was about 346,000. And then you had, of course, for the human resources to look at the capacities of each of these organizations and who runs them. We had to create detailed formats for that, collected data on that, on human resources and cost through structured formats. Our qualitative data is largely your contracts, scheme documents, that sort of thing. And of course, key informant interviews with the trust, the insurance companies, the support agencies, and all of that. The analysis, descriptive, and for the qualitative thematic coding, deductive, inductive, and then of course we had ethics approval from the Board of Research Ethics. Okay.
Take a question. How are these insurance companies selected? Through a competitive process or?
Yes, they're selected through a competitive process. I'm coming to that as to what that, they are. I'm sorry, I forgot to mention earlier. If you have a clarificatory question, please feel free to stop me. I'm happy to answer. Any larger questions, maybe we can take at the end. But right, so just to give you a brief snapshot before we go into the actual results of what the magnitude of the scheme looks like in each of these states. You can see large numbers, of course. This is India. Every state is like a country. And then wide variations as well. So it's also very difficult to get states within India to compare with each other. So that was not really the motive. The motive was really to just compare the 2 models. These selection of states was also in, based on NHA's interest also in looking at what was happening. So you have, large numbers. What is more important is really this, to give you a sense of what proportion of the population is eligible for PMJ. And you can see that in, in all of these 3 insurance states, 2 of them have universal eligibility. In Punjab as well, the eligibility is quite high. in these states, the eligibility is actually quite low. All right. And this is something that's usually quite surprising, that in UP, it's, less than 40% of UP's population is actually eligible for PMJ. Now, this speaks a lot to the SECC criteria and all of that, but that's a different story. We can talk about that later. And another thing, although registration is not a prerequisite, like if I'm eligible for PMJ, I can walk into a hospital, just have my Aadhaar card, get treatment and get registered. I don't have to be pre-enrolled or anything of that sort. But there's a lot of communication that goes out to get people to register so that they know they have these benefits. And that penetration, despite all of those efforts, is not very high. And so therefore, that also has some impact on what you see later. All right. So let's look at the purchasing agencies, because that's the focus here. Who are the purchasing agencies in each of these models? Now, the first thing to see here is that although I said there's trust, which is government, and there's insurance company, which is private, you can see that there is a mix of the government and market in both models. Okay, and what do I mean by that? Let's look at insurance first. Of course, you have a trust and an SHA in all states. You have the insurance company, but then you also have the third-party administrator. Now, these are administrative claim processing agencies that are further contracted by insurance companies to administratively process claims. Now, in these three states, most will always have a contracted TPA. You can see JK has 1, Punjab has 3, okay? But Meghalaya's insurance company did not have a TPA. Okay, so there's further variation even within the insurance. In the trust models, there is this thing called an ISA, or an implementation support agency. Now, what is this? It's called an ISA, but essentially they're the same kind of company as a TPA. Okay, so they're also regulated by the Insurance Regulatory Development Authority of India, but they are just administrative contractors. But they are contracted by trusts in trust model states to do several functions. All right, so you have a mix in both models. And then you can have other agencies as well. In this case,
It might be on your end, I think.
yeah. So basically here you just have this, but otherwise, what is important to remember here is that you have all of these agencies. And just to highlight, Meghalaya doesn't have a TPA, and among the trust states, Haryana doesn't have an ISA. Okay, so variation, and I know this is a little bit like scripted and tedious, but within the 6 states itself, we found variation in the model. And why this is important is because I'll come back to this. There are some differences in the results in these 2 states compared to their counterparts. All right. So Mr. Shah, coming to your question, what is the way in which these agencies are contracted? What are some of the terms? So if you just look at the key things, how are they selected? The insurance companies and the implementation support agencies are selected based on a bid. They bid for these contracts. They bid based on a rate, which is a per family rate. All right. And the lowest bid wins. All right. The contract. And remember that's also something I will come back to. What are the payment terms? Now, usually insurance companies will try to retain, minimize claim payouts so that they can retain the maximum amount of premium and make profits. In these contract terms, there are caps. So insurance companies have a fixed administrative cost that they can retain as their profit, okay, which is linked to the claims ratios. Okay, just to clarify, claims ratio, your total payout upon your total premium. Okay, so therefore, based on the claims ratio, they could either keep 10, 12, or 15% as administrative cost. And then there may be some variations in that depending on the size of the state, but otherwise the rest is returned to the government. All right. So they can't keep all of the surplus. They can keep a certain percentage of the surplus, and the rest goes back to the government. All right. Also, if the claims ratios go very high, okay, now the loss bearing risk also gets limited. So if it goes above 120%, The government and the insurance companies share losses in a 50-50 ratio, all right? So there is this unique sort of contractor. All right, so the other thing in implementation support agencies, here there's no such thing. It's a fixed fee, it has nothing to do with your claims ratio. And that's all the money they get. There's no question of a claims ratio there. And the performance appraisal. Now, the contract terms have very clearly defined performance indicators for both the agencies, which are linked to, how they process claims, the correctness of the processing, the timeliness of the processing, and there are financial penalties that are involved if this does not happen correctly, and that is implemented.
Can I ask you, in your sample, do you know the insurance companies that were selected, the rate that they bid, how much is it lower than the premium that the trust would have?
Yeah, I can show you that data.
Okay.
I'll tell you what the price, the rate that the government sets,
Yeah.
and what are these premiums in comparison. We'll come to that one. Okay, all right, so this is just the background, the contract terms. We're going to go to performance, and you'll be able to know why this is happening once, because I've already told you what the contract terms are. So the first thing I said, we thought trusts would provide better access to care. Insurance companies would limit access to care. What are we seeing? We're seeing that the overall utilization is actually higher in the insurance states than in the trust states. Now, this is just all utilization, okay? All pre-authorizations registered. Stay with me here. I will come to a more specific indicator later, but this is just overall utilization, which is almost
how you develop the hypothesis that right, insurance trust will have higher utilization. If the insurance company gets 12% of the claims, they will want to pay out more claims and get people to utilize. The incentives on them, so they should have much higher. But your hypothesis was trust was new.
that was based on the earlier experiences. So this is the contract now in PMJ, which is exactly what you're saying, which is why we're seeing this, right? We're seeing that now they don't have incentives anymore to hold on to payments because they need to achieve a certain amount of claims ratio, right? And so we're not seeing that kind of.
Your initial hypothesis is that the trust will pay out more, give more access to people.
Despite the fact that PMJ had designed these contracts, they were still not sure that this was going to work because of the enforcement of the contracts. Because that's another thing, right? Because it can be designed well, but then we don't know if the states are actually going to enforce it. So, you see that there is higher utilization, but there were some differences here, state level differences in the benefits packages. Meghalaya includes outpatient care and diagnostics. So what we did is we just looked at something more specific, which was just hospitalization rate. So we excluded all, the daycare packages, all the outpatient diagnostics, all of that, just stuck to hospitalization, and also compared it to another source of population level data, which is the NSS data on hospitalization rates in India for each state and overall, just to see whether access to care also as an outcome had improved under PMJ. And if you look at it, you'll see that first of all, in the two models, it's comparable. Hospitalization rates are really pretty much the same. And even in the states, of the 6 states, for 4 states, UP, Haryana, Meghalaya, and Punjab, you can see that the hospitalization rate under PMJ is actually higher than the population level hospitalization rate. Okay, and so you can say that the scheme has increased access to care, okay, and there are no real differentials in that, irrespective of the model that is being used, all right, based on this data. The second thing was looking at rejections. We were worried, and so was the NHA, that there would be high rates of claim rejections. But if you look at it, you'll see that the rejection rates were actually higher in the trust states than the insurances. So this was contrary to expectations. However, as Professor Shah pointed out, with these kinds of contract terms, there might not have been an incentive anymore really to reject claims, right? So therefore you see that the rejection rate was quite low in both models, and the 4.8 is in trust models and 2.3 in insurance models. But what I want to highlight here is that, one is that there is an exception in either model. So you can see that Jammu and Kashmir has a very high rejection rate. Haryana has a very low rejection rate compared to the counterparts. And we'll explore that a little more because implementation is linked to a lot of other factors. And so that's one. The second thing is you'll also see that the rejection rates across states are higher for public hospitals than for claims coming from private hospitals. Okay, so that's concerning, right? So one is we're seeing different results, but also seeing that there's an exception. So we need to know why that's happening. And we're wondering why are public hospital claims getting rejected more than private hospital claims? And so the major reasons for rejections really, the first thing was public hospitals didn't seem to have the ability to submit the requisite documentation and to do this in time. Okay, and because of that, a large number of claims were getting rejected. Okay, and that really pointed out to just the fact that there was not enough capacity building. So while there was no real wrongful use of the scheme, there weren't instances of fraud. It was just that the hospitals weren't able to submit the necessary documentation required for their claims to get approved. Now, these high rejection rates in Jammu and Kashmir, 6.4 is an aggregate, but they had been higher in year 1 and year 2. Okay, so at this point, what is important to know is that the government intervened. So despite these contract terms, Professor Shah, we still saw very high rejection rates in JK, which the state then intervened to examine. And then they found that a large number of claims were actually wrongfully rejected, so they revoked them, and financial penalties were levied on the insurance company. All right, so this sort of governance intervention remains extremely important. It's in the contract, but it's not always sort of enforced in the contract. The other thing was because they saw that there were these capacity problems, they adjusted the terms to basically make, to allow public hospitals more time to submit their claims, besides also building capacity. So basically what this tells you is really that, even when the contract terms are there, they might not get enforced, but if government steps in to enforce them, the state health agency or the trust, it makes sure that this works the way it's supposed to work.
Can you please tell me what is the appellate tribunal or disciplinary redressal mechanism? To your second point, within government intervened and levied penalties on insurance?
Yes, so there is a grievance redressal committee, okay, and if the insurance company feels like this is wrong, you mean for them, right? Yeah. So if the insurance company feels like this is not justified, they go through the grievance redressal committee, and that grievance redressal committee then goes, beyond NHA, it goes to the governance body of the state health agencies, which are, the senior bureaucrats, and it goes above. So there is an appellate mechanism, and they can dispute that. Okay. The other exception was Haryana. Again, if you remember, Haryana doesn't have an implementation support agency. It does the entire scheme on its own, okay? And Haryana's rejection rate was lower than that of trusts. Now, in Haryana, what was interesting is that the state health agency just does everything through their full-time medical doctors. So basically, full-time government medical doctors are deputed to the state health agency and they manage all claims. Now, when we were talking to them about how they do this, they say that, because they are full-time medical doctors, they don't have to follow like a checklist, like an implementation support agency would need to. They can basically just sort of understand if a doctor has deviated from protocol, why they might have deviated, what are the reasons for them to have deviated, and they won't reject claims unnecessarily. And so they call this the customization of claim processing. And they said that, this allows us to avoid unnecessary rejections, and it also helps us do this faster. And if you look at it, they also do this process much faster than the other states. Okay, so this is interesting because they don't have an implementation support agency. Okay, I know, I need to put in time, right? Okay, there's still a while to go. Anyway, so implementation support agencies are also subject to market conditions. They require very close oversight as well by government. They are affected by high attrition rates of personnel and also a difficulty in finding qualified medical doctors. So this is a theme that was, we found in this study and a lot of other work that we've been doing as well, with states grumbling about implementation support agencies and, how that they need a lot of oversight because otherwise they can sort of left alone, things may not go exactly the way they want it to go. And so, this was something that also we flagged. Okay, so coming to claim management efficiency. Okay, the first thing, just looking at who are the human resources, and I'll be brief here. If you look at it, you'll see that insurance states have a smaller workforce and they're processing a higher number of claims with that smaller workforce. So if you look at the families served and the claim to workforce ratio, you'll see that, it's always more work done with fewer people really in insurance states. So they're obviously able to handle a larger workload with fewer people. Now, whether they're doing it well and correctly or not, I'm not saying that, okay? But they're just able to do more with fewer people. In terms of timeliness of payments, the guideline says 15 days. Hospitals should get paid in 15 days. All right. Insurance states are able to do that. The median of 14 days, trust states 48 days. So trusts are definitely much slower in processing claims, but Haryana does it in 28 days. Okay, so Haryana does it much faster without the ISA, just the government doctors doing the job. And insurance states take longer. Now, when we talk to hospitals, they weren't too upset with all of this, like in the trust states. I said, are you getting your payments? They said, yeah, it takes time, but it comes. As long as we get monthly settlements, we're okay. So, there are trade-offs. Yes. So, all right, I'll skip through this. This just gives you state-wise. You can see huge delays with the trust, but faster processing. Coming to the claims ratios, all right, and the management of financial risk, which is really important here. So you can see, and here this is the 3 insurance states, comparing them. The benchmark rate set by the government is 1052, 1,052 rupees. The premiums that were charged here are much lower. Okay, and this is like not even $10 really, an annual premium. And what we see in Punjab, okay, so Punjab, Jammu and Kashmir, and Meghalaya, 3 insurance states. I'll just tell you quickly what happened in each of these. Punjab was reporting a claims ratio exceeding 100% consecutively, all right, year 1 and year 2. They did increase the premium from the first and second year, but it was still not high enough to meet the scheme demand. And in the third year,
clarify what you mean by premium here.
the premium
It's the premium that they bid
and got also, right? That they were paid that premium.
from the government.
Yeah, because that's the rate they bid at. Yeah, and so, and this, despite this happening, despite these extremely high claims ratios and these inadequate premiums, in year 3, they got a new insurance company because this company bid an even lower premium. Okay, now this didn't make sense to us. So, we're like, what's happening here? But this is the thing, like, it's always the lowest bid that gets the contract, and maybe you can explain this further. Yeah, yes.
Were they trying to split the number of application claims by quoting it low?
No, it was just one bid, because that's the rate that they got. And then what eventually happened, they got selected, despite knowing that this was not a tenable premium to quote. They got selected, and at the time when we were doing our interviews, they had stopped reimbursing hospitals because obviously they couldn't. They didn't have the money to do it. And eventually this got written. Punjab has now moved to a trust mode. That's the last thing said. But basically, okay, let me just come back to, I'll tell you what happened to JK and we'll come back to this. JK also, initially the claims ratios were okay, but after they made the scheme universal, their claims ratios also went above 100%. Their premiums are still quite low. They're a little better than here, but after universalization also they're still quite low. And now we asked insurance companies, like, what's your motive in all of this? If there's a cap, right? You're not allowed to make as much profit as you want. Why are you still doing this? And basically what we've been given to understand across, whether it's your private commercial insurers, and all of these are private commercial insurers, but you also have the government, the national insurance company, all those. But basically schemes like this, because of the huge numbers of eligibles, even if the per family premium rate is low, the total premium that they earn is huge. And they don't get that from any other kind of product that they sell in the market. That is money that they're able to get investment profit out of. So they invest that money, and that's how they make money from that. So it's the investment profit and not the underwriting profit that's typical of insurance companies elsewhere. That is really the incentive for insurance companies to bid for schemes like this. All right. And that's why they continue to do it and are very much interested in doing it. And this was important to understand. Now, this is the two states. Meghalaya, very different picture. Meghalaya is a small state, always adopted the insurance model, very happy with the insurance model, but look at their premium. Their premium is way higher than the benchmark, which is 1,052. Their premium is close to $20 and much higher. Okay, so for that state, this is a lot of money. Okay, this is like more than 100 crores that they pay every year. And their claims ratio, as you can see, is at that sweet spot where they get the maximum administrative costs. All right. So here it's kind of working for them pretty well, but that's an extremely high premium. All right. So what does this mean for costs? Okay, as expected, you'll see that the administrative costs are really much higher in an insurance model. And just to flag here, this data is just meant for comparison. It doesn't necessarily include all of the costs. Also, the salaries of the government officers. These are basically underestimates, but they're comparable. All right. And if you look at it, you'll see that, the administrative costs per beneficiary family and per claim submitted are much higher in the insurance model than in the trust models. All right. So that's basically what we found. And so just to summarize what we're seeing, as far as the organization of purchasing goes, you see that insurance companies under PMJ contracted for a limited set of purchasing actions. Not all purchasing decisions are made by them. The state still retains a lot of those purchasing decisions, as well as their contracts being designed in a way that there are limits on their profit making as well as their loss bearing risk, which creates a different set of incentives and disincentives. Both models have a mix of government and market elements. As you can see, even the implementation support agencies and trusts have their problems, so to speak. In terms of access, we don't see that access is really being limited because of the way in which the contract terms have been defined. The rejection rates across the board are much lower than used to be previously reported in the earlier schemes. Just to give you a sense, we're seeing 2 to 4%. It used to be 16% and in that range before PMJ. And where there are still insurance companies that try to game the system, we see that if there is sufficient oversight of the state, it can be brought under control. So basically the contract design appears appropriate, but the enforcement really remains necessary. What is important is the oversight to avoid wasteful use of care. Because insurance companies now are not incentivized to reduce claim payouts, are they making sure that there's no fraudulent use? Okay, and that's one thing that we flagged that has to be further studied. We did try to look at that. We couldn't get the data that we needed for that. We did it through some proxy indicators, but we weren't confident enough to say whether trusts or insurance companies were doing that part better. But that's an extremely important part of this whole story about, which of these models is able to detect fraud. In terms of management efficiency, The insurance states definitely seem to be doing a better job, timely payments as well. But of course, we have to see if instances of fraud are being missed. So in terms of the market dynamics, the problem here really is this perverse incentive to bid at untenably low premium rates. And that's something that really needs to be taken care of. So this was something that we proposed to NHA, which they thought was important, that states must set benchmarks for actuarially determined premium rates, not these arbitrary premium rates that don't really make any sense, that are based on the expected utilization of care in the states. And those should be a part of the technical criteria when evaluating bids, so that it doesn't come down to your L1 rate, the lowest rate basically. But these companies are sort of, done away with in the technical round itself. This is really an important thing even for the trust model, okay? High attrition and all of this, using contracted agencies in the trust model, it fulfills capacity requirements, but it also has implications for long-term institutional building, which is really important for a scheme like PMJ, which is meant to be the platform for universal health coverage. We have to build institutions. And so, how much we depend on contracted resources is really an important thing to consider. And then, of course, finally, your administrative costs are higher. And seeing that claims ratios are going higher and higher, premiums will have to increase. So the costs of the insurance model for sure are going to really increase going ahead. They're already higher, but they're definitely going to increase going ahead. So yeah, I think that's about it. I want to acknowledge the project team. We worked with the National Health Authority, Praveen is here, and with the WHO Country Office for Health Financing. And I want to acknowledge all the members of this, state health agencies and all the support agencies for their cooperation. Yeah.
Thank you. Let's open the floor for questions. As of now, what percentage of, as of today, what percentage of the agencies are trust model? I understand that the insurance model is sort of
Yeah, it's on the decline.
almost,
Yeah, so 23 states are trust and 10 are insurance or mixed.
and the insurance model tend to be hybrid, not pure.
There's still more pure, so 6 are pure, 4 are hybrid.
Mhm.
Yeah, but even in the hybrid model, what happens is that the insurance company will process claims up to about 100,000. And that's usually the bulk of the claims, because the high value claims, which are supposed to be processed by the government, where the insurance company is not involved, are very few claims really. Most of them are in that sort of range. And so it lands up becoming pretty much of an insurance. And the reason they do that is to limit the premium. Because, yeah, so that's...
I'm just curious if I would just ask one more question. The problem that you described about the insurance model, that is they bid and they underbid. That was an old problem from RSBY. And why after all these years, when TMJY inherited it, they continue with that approach?
So this is something that I've also been, wondering, why, and I think
Maybe
maybe
Praveen
Praveen
can
can
explain.
help us with this. It can be taken care of in the technical criteria, as I've given to understand, but the L1 rate and going with the L1 rate is something that, I'd be happy to.
So there are, so basically the question is why L1? So, right?
Yeah, like even if they bid a rate which is
Is-
not going to be,
Right.
sufficient to manage the scheme,
Mhm.
why is government compelled to award the contract?
It has largely to do with the way GFR or government financial rules are designed, which are rules for everything that government does. It's not limited to health insurance. There is a provision for, so there are like 2 types of bids. One is plain L1 bidding. So you decide a benchmark. The company coming will have this turnover, this much of manpower, this much of like experience, and so on and so forth. Once that benchmark is crossed, whichever companies qualify, the lowest one is selected. Now, what you suggested is in India known as QCBS. That's a limit. So that is also used in some types of contracts, but typically not contracts having operation heavy or component. For example, you want to select an architect firm or IT developer, then that kind of system is used where experience, turnover, etc., are awarded some marks. So not only they are qualifying nature, but they also add to a component, like it becomes AX plus BY is equal to so and so. So that A and B is typically like 60-40 or 65-35. So that is possible. Coming to the first question, rejecting L1. I mean, the plain simple answer is fraught with immense risk. For somebody who is rejecting, he will be seen as somebody who is rejecting a low offer, ultimately causing loss to the government exchequer. So it's a kind of risk avoiding mechanism by bureaucracy to some extent, and it takes a lot of reasoning to reject. Now, it is possible to reject. In certain cases, for example, I want to construct a road and I know that it will cost 100 rupees and I get a bid of, let us say, 60 rupees. There is a possibility that I write down reasons and reject it. Here, those kind of estimated costs, which is actually a lot of things to do with the way that state has, I mean, demographics of state, access to care, that kind of benchmark is not available generally, easily. It is easily available for hard works like construction of building or roads, where you can estimate what will be the likelihood cost. Here it is very difficult to estimate because every state is different, the kind of healthcare is different. So the safest way is, if somebody is bidding low, accept it and go
Can the
ahead.
state not do an actual determination?
It's
Then-
because of lack of
That's it.
capacities, you don't have that benchmark determined. It is possible theoretically, but how do you compare what will be the estimated cost? So there are like 3% per year hospital admission rates with approximately rupees 15,000 per hospitalization as the cost, etc. But I think it has more to do with the risk. So there are like a few bureaucrats here. They will agree with me. Rejecting L1 is very.
That's what I want to. He's right, actually, like in hard works, engineering departments. In order to discourage the lower pays, which ultimately result in non-performance and loss of service to the public at large. So we increase the earnest deposit money by 10% of the total contract. So that is kind of disincentivizing for the lower bidder, that if you bid lower than the contracted value, the like projected value, then you will have to invest and keep with the government 10% more than otherwise.
Yes.
So that is a kind of disincentivizing thing for him, to nudge him that you bid at the right price.
I have one experience in which I got less 60% of the value quoted by a contractor for one work. So I was intended to I was keen to reject it, like something which should cost 100 rupees was provided at 65. And I asked, so typically you ask, justify your rate. He said, I'm doing it at loss because I see this as a cause of my nation, and I have spent a lot of money.
A lot of that too.
Yeah. It happened to be a work in some religious importance place, so my offerings to the god and all that, and it was legally, it would have stood in the court of law, so I didn't reject it.
Okay, let's open the floor for other side. Yes.
You make an interesting observation that insurance companies get in bulk premium amount and then they get some money on the investing it, and then they cross subsidize it to, to the underwriters. So doesn't this thing take care of this lower bid problem, or it takes care to some extent?
Doesn't seem to be taking care of it because this is still happening very much in the market and, in fact, I kind of even verified this with the, the national insurance, the public sector insurance companies, because I was wondering whether this was just a private sector insurance company trend. And they indicated that they do the same thing, so I don't think it really sort of makes up for me.
Just a quick one, in your last slide, when you summarized. What is the cost comparison, the actual insurance claims so per house, which is higher?
Yeah, so that is usually because you saw utilization was higher in the insurance model. And so if you look at the unit cost, if you also take that into consideration, your payout, your unit cost, that is very variable. There's no like one model higher than the other model. So like, because that's also a function of, the kinds of claims. So like Haryana had a very high cost, although it was a trust model, but that's because their payouts are very high because it's mostly like tertiary treatments, because Haryana has all the tertiary hospitals there. And so that's really a function of what claims are being generated in that particular area. So that's why we didn't put those numbers. I have those numbers, but that can be very variable. And there was no sort of constant, one higher than the other, which is very variable across states.
The providers, they submit claims on a fee for service basis, I imagine.
So these are basically case-based payments. So they are bundled payments. Yeah, and they include everything to do with the treatment, your hospital stay, the cost of your doctors, also your medicines, and it's supposed to cover your drugs up to 15 days also post-discharge. So it's a bundled package rate. It's not a fee for service payment, but it's not as sophisticated as a DRG based. They're going there, they're working on that, but right now it's a crude sort of bundled package.
Performance management to see how the hospital is doing against the bundle payment that they're receiving.
So as of now, that's something that definitely most schemes would do. This isn't being monitored very the data is there. The state does sort of check these things, but it doesn't affect payments as much. Like if you're looking at indicators like length of stay, for example, because for surgical treatments, it's basically a full package rate, irrespective of how many days you're in hospital. But for medical management, it's a per diem sort of package rate. So you'll see that usually the length of stay will be higher for medical management cases and lower for your surgical cases. Now that data is available, you can see it, but it hasn't really, what they will do is that they will speak to the hospital and, try and see if they're doing, they will try and see if that's justified or not. If there is very clear evidence that they're prolonging the length of stay, then they can, of course, cut their payments. They can do that while reimbursing claims. But a lot of this happens in retrospect when the data is analyzed. It's not as clear when you're processing it. But it could be. It's not that it's not done.
I'm not sure if you clarified this and I missed it, but how come Kashmir and Meghalaya was 100% eligible and UP was only 30%?
So they have made the scheme universal. So Meghalaya has so based on SECC criteria. So SECC criteria is something that's set by the center, but states can choose to expand the scheme.
And how is this like lowest on hospitalization despite 100%?
Yeah, so if you look at, so I haven't shown you the hospital data, but if you look at it in Jammu and Kashmir, the number of hospitals, the available hospital beds are also lower. The bed density is lower. Also, initially it took some time for the scheme to really take off. The utilization has picked up more now in year 3 and would have picked up even further. But yeah, so there, and most of the hospitals in JK are public hospitals. So if you look at the empaneled hospitals, the majority is public sector hospitals. And so just, you know, in terms of your supply side, there are limitations there.
Yeah, I was gonna just ask, like, you skipped through it real quick, but was curious, like, you know, if you noticed the difference in performance between the states that have like the two system, the public and the trust system, and the states that just have like one system. I know you went through briefly, but I was just curious, like, if there was like a major difference between like the outcomes of the states that didn't have that.
Which outcomes?
Like performance outcomes, or I think like you went through.
That's Oh, right, okay,
Yeah,
so
yeah,
when I was talking about just pure public
Yeah.
amongst the
Yes,
other
yeah,
trust
yeah.
state. Yeah, so that was basically Haryana. So Haryana does not use any kind of contracted private agency for you know, this, they can hire like data entry operators and that sort of thing, but not for processing claims and doing the technical tasks. So they basically, you know, had lower claim projection rates, their processing times were much shorter. And they just seem to be doing a more efficient job. So that was the main difference that we saw in terms of, also their utilization is the highest, but that's really because if, you know, Haryana has a lot of very good, you know, tertiary care hospitals. And so, you know, a lot of people also come there to access care. And so that could be driving up utilization.
I do think that your interpretation of the utilization result need to be very nuanced.
Yes, yes.
It
Some
is
of the
not, it
confounding
is,
factors.
yeah, it is not just due to the way the model is, the purchasing is organized. There are many other things, the variation in benefit package, the variation in supply side, all that. I mean, too.
Absolutely, yeah. So if, you know, if that wasn't clear enough, like utilization could be determined by several factors really. And in that first slide, you know, I didn't mention it, but it was there that, you know, the registration rates were also higher in those states, and that there was awareness. We actually did try to get other sources of data for some of those factors, but we just couldn't, you know, get it in a way that could adjust for all of it. But yeah, there's higher eligibility registration. There's also higher awareness in these states, and the supply side, which is an extremely important component. So yes, definitely. Thank you.
Yeah, I just had a couple of like very basic questions. The first is, well, maybe we can take it either way. The first question is about how does the data vary if you compare government hospitals versus private hospitals? Is there a difference there? And the second thing that I was just wondering is that, so when the claim is actually made, is it made by the hospital or by the person being treated? And where is the person in the whole scheme, like the patient? And the reason I ask for this is that Pakistan has recently had like a similar kind of a system in one of the provinces has always had it, but the other province is now doing it. And I knew someone who went there for a treatment, and then I looked at the claim afterwards and I said, oh, so you got this treatment? And I was like, I don't know. And I said, did you get this done? Like, I don't know. And, you know, and this was very interesting. And the hospital had billed for so many things that the person hadn't done, but just because the state was going to reimburse them, the person by the end of it said, I don't really care, like it's done. They just asked me to sign this document at the end and, you know, I have nothing to do with it now. So it was very interesting. So I just wondered, would that happen there in this, or is there, are there checks and balances there? And where is the human there? Like, you know.
So basically study. So therefore it's very focused on these intermediate organizations. In all of this, the most important stakeholder is the beneficiary. And there's a lot of work around that as well, but not in this particular study. So does fraud happen? Yes, it does. You know, there are instances of fraud in all the states. And I think that all states will be happy to tell you that, not happy to tell you, but basically will admit to the fact that it's happening. There are checks and balances. So there's a national anti-fraud unit, there's a state anti-fraud unit. There are IT capacities being developed. This, you know, all of the claims are managed on an IT database, which have triggers. Triggers get investigated. You have people doing desk audits, people are doing field audits, you have hospital audits, the contracts have all of these terms. And a lot of that happens. We've checked the documentation. So there is a mechanism for checking fraud, but it's not foolproof. And I think that's something that, you know, Professor Shah was like an expert who will tell you that it happens in any insurance scheme. But Now, whether it's happening less in BMJ or not, that's something that I don't think we have the data to really say for sure as of now. And there could be instances where people don't actually get treatment, but a hospital bills. There's also been instances of like many hospitals actually being set up when schemes like this happen, because there's an additional source of revenue. And so that is, of course, a very important part of this whole story and which has to be looked at more closely. In terms of your first question on the differences between public and private hospitals, so I don't know if you have a specific performance factor in mind. In general,
yeah.
so this can vary across states. Again, remember, at the national level, we have 50% of all hospitals are private, about 50%, but it can vary from 7% to 77%. So each state, based on its supply side, can have a very differential proportion private sector or government sector. Also, in terms of the type of care that is being provided. Most of the private hospitals are small, medium-sized private hospitals. They're not the large, more than 100 beds tertiary hospitals. So the public sector is still an important provider of care. But having said that, although the private sector, so just national stats, although the private sector is 50% of the empaneled hospitals, it contributes, about 60 to 70% of all services delivered. Also a disproportionate value of claims. So the more expensive claims, the tertiary care, all of that is more sought in the private sector than in the public sector.
Can I follow up on that point? I do think that since you only have 6 states, it's important to add to that the number of public hospitals and private hospitals that each state
Percentage, yeah.
and the type of hospitals. Because I think that makes a difference to the
We have all of that data.
of your findings.
Like what is going on in states where there is like comparatively like a stronger public health system? Like, do we have a sense for it?
It's a higher percentage.
So in that, where the public health system is strong enough, first of all public hospitals are deemed empaneled in BMJ.
Okay.
Yeah.
So all public hospitals are a part of BMJ. If they deliver care as per the benefits package, they get reimbursed. And the rates of reimbursement for public and private are the same. So it's not, So in that sense, they're very much, and that's a great thing because then they will be, getting an additional source of revenue through this.
Yes,
Can I add more?
yes.
Sure.
Please do. It's like Tamil Nadu has a very strong public health presence. If you compare the private and public presence, it's going to be like not 70 to 80, but it will be like 60-40%. Still, private sector would have a more say because the accessibility to the private care is equivalent to the public care. So they perform. States like Telangana, where again the presence is largely majorly in the cities for the private care. Yet people there are migrating. So if you compare that rate, irrespective of having stronger public care, still private prevails.
Right.
So it all depends on the geography,
Where you are.
accessibility, and stuff like that. And with respect to Yahoo, so I think trust states, whatever trust or insurance model is generally the hospital which claims the insurance. Never a person is expected to go and submit any paper for that matter. The only thing they will carry is either their Aadhaar card or ration card. How these two states manage, which I've seen, the state on its own behalf has a party who sits in the hospital. So these are mitras or friends of public. So they somehow monitor the documentation signing is done properly or not. The check and balance at the into spot. And states which have insurance model invariably has a third party assessment. So that's again another level of
check.
No, thanks. I missed to answer that question. So basically, the hospitals get reimbursed.
So there's one more angle to that. A lot of public hospitals simply don't bother to raise the claims. This is a big reality.
Yeah, but you have the higher
I
rejection.
mean, I'm getting my budget through line items.
Doesn't matter.
Yeah. That's a question.
But it's additional revenue.
Right.
You have to do paperwork.
Yeah.
What I was going to ask you.
the money, they also have a system for incentives, team-based incentives, but there are incentives, but some states are not doing this. They're not using it because they're very worried about, will there be some kind of coming up
Right.
within the public hospitals. But in the states that are doing it, in fact, the utilization, the claims that are being generated in the public hospitals has really gone up.
So. Yes. So the hospitals are starting to return.
Some states started clawing back money from hospitals to state exchequer. Then we issued a guideline to stop doing that or maximize that clawback to some 25% or something. And rest of the money remains with the public hospital. Now, again, in India, the government official working, he has to follow a huge, long process to spend anything, which is an additional work.
You don't want
If
to do
there
that.
is no additional financial incentive, plus whatever services you are delivering, everything is actually paid by the line budget items. So why have this additional task? So this also is a significant factor is having less number of claims getting
And the
generated.
capacity is to really, put these claims together, like I showed, JK, it's still weak. I mean, having people who can actually put together all the documentation, upload it on the system, internet is not working, then the IT system is giving trouble, TMS is slow, that's a very common thing here.
Punjab came out with one reason why Punjab went beyond 100% is that they selected an agency again on L1 model, which acts against the insurance company. So the agency is responsible for employing one person in every hospital. And whatever the revenue gets generated for that hospital, a fixed percentage of that goes to that agency. So this agency has incentive to push claims and insurance company has incentive to reject claims. So they kind of counterbalance. And this actually shot up the claims in Punjab significantly. And that's one reason why they stopped paying after some time because they started incurring losses. And I come back to the earlier low insurance side also. One reason why the insurance rates were very low and the Jammu Kashmir episode happened because initially the coverage was not universal and the database is bad. So there are like a lot of errors of exclusion, inclusion, both. So the insurance company, while submitting its bid for premium per family, takes care of that. So they know that I'm submitting insurance policy bid for, let us say, 100 families. Actually, only 70 families exist. So let me divide my premium of 70 on 100. So the per family premium comes down. What happens? 40% of coverage all of a sudden becomes 100 by change in the policy. Now there is no such chance to spread premium on ghost families. And then they start facing issues. So that's the reason of low insurance premium and subsequent complication of high rejection rates, which led to that fine and all that.
It's very interesting.
Do you have a?
No, I want to thank you for a very interesting presentation and wrestle with the interesting question. You're really talking about the third party, the insurance company, when you're contracting, taking on two kinds of risks. One is bidding on the premium. And so if they exceed the premium, then they have to take certain losses that before the state come back and share that risk. The other part though is the risk or the profit is the claim. The process of claim. Here, because I dealt with the United States as well as other countries, I can tell you how much claim processing really costs. In the United States, less than 5%. Okay. And in large companies, private insurance companies, insure, let's say, Harvard University, only charge Harvard most is 4% for claim processing.
Hmm.
So when you allow for 10%, 12%, that's,
Huge problem.
there is a profit margin
So-
there.
So when we
So-
talk,
The insurance company has to think, I may lose out on the premium side, but I'm gonna gain on the claim side.
Hmm.
So-
And where is
There's
that,
a margin.
that's balancing? That
when we talk that, you said that the term administrative cost is misleading. It's really profit.
Yes. It's allowed, right, how much profit margin you allow?
I just have one last question for you before we wrap up is, I find it fascinating for you to say that the trust model use medical doctors to review claims and they are deputized somehow by the government to come from the public hospitals and they, instead of seeing patient, they become claims reviewer for a year, 2 years. I mean, how exactly does that work? And also in the insurance model, then do you require the insurance company to also use medical doctors to review claims?
So you need, there are, to review claims, there's a first level, which is a claim, executive, who is somebody who, checks what, documentation based on a checklist. This is not a doctor, this is.
Right, those are
Right.
just papers.
And then the second level, which is the actual approval, is a claim processing doctor. That's the terminology. And that's supposed to be a qualified doctor to do the final approval or rejection of a claim. And this is irrespective of whether it's the insurance or the trust. That's the guideline. And so you do need qualified medical doctors. Now, having said that, in your TPAs or implementation support agencies, many times these might not be MBBS, they might be, other systems of medicine, trained through other systems of medicine. And that's where I said that they have also difficulties in getting qualified medical doctors to fill those positions. In Haryana, they're doing it with regular government doctors. Now, these might not all be taken out of hospitals per se. They could be part of the health department, but they're still, doctors with an MBBS degree and have worked in health. And so based on their input, and, of course, this is not, we've also seen this because many times, and there was one quote there that indicated it also, is that when there is a back and forth between the claim processing doctor and the treating doctor in the hospital, if there's a qualified doctor at the other end, the claim processing doctor is a qualified doctor, they have a much better negotiating
No,
power.
I fully agree.
So
and
that's why
in
it's get
I
the
fully
job
agree,
done.
but as we said, I think in most other systems that I have seen, is using the qualified doctor or the professionals to discuss with the practicing medical doctor for outlier cases, right? But whereas you are saying that they are actually reviewing every claim, which is.
Yeah.
They're supposed to. I mean, based on the way they explain it also, I'm sure there are some cases that they don't need to go into as much depth because there will be some cases that get flagged for them in a special way. But that is a step in the process that has to be done. So
Yeah, in other countries,
Yeah.
Yes,
advanced countries, actually physicians review less than 10%. Right? That's really trying to say is that medically, what's being given is
Necessary.
medically necessary and appropriate. Is otherwise, there are computer programs right now for sale to screen for every condition, symptom, what is the appropriate treatment. And if you did something inappropriate, kicks out. First is a nurse review in America or in Southeast Asia, in Malaysia, in other countries. Then is at the end, then the physicians
Comes in.
have to review it. Those are the most complicated cases. It's less than 10%. So I just want to give you the international practice.
I think now, so Steve first launched, there were no standard treatment guidelines as well. Now that has come into place, and I think once standard treatment guidelines become very much a part of the system and everyone's comfortable with them, there could be scope for sort of weeding out this dependence on doctors really, because then everything will be very clearly set and less scope for the back and forth.
Great. Well, let's give a round of applause. Thank you.